Hi, I'm Dr. Avanti Singh. In over 20 years of practicing both Western medicine and Eastern healing traditions, the most important thing that I've learned is that healing is a journey we take together. So on this podcast, I'll be demystifying Ayurveda and other integrated medicine, showing how these simple, ancient practices are the keys to unlocking a healthy modern life. We are all healing catalysts because healing starts within. It starts with you, and it starts right now. This is a Soulfire production. Episode number 108. Okay, everyone, grab a notebook and a pen because you are going to learn so much on this episode. Hey, friends, I'm so happy to be back with you again here on the Healing Catalyst podcast. And if you're new here, welcome. I'm Avanti, and I am so glad that you're here spending part of your day with me. Today on the podcast, we are rounding out the November intention of hormones and our health with an incredible episode all about women's sexual health, including everything that you need to know about perimenopause and menopause with my guest, Dr. Somi Javaid. Dr. Javaid is a board-certified OB-GYN, a thought leader in women's sexual health, and a menopause advocate. She's also the founder and lead chief medical officer of Her MD, a team on a mission to make women's healthcare exceptional by educating, advocating for, and empowering patients to take control of their health concerns. Dr. Javaid is also a TEDx speaker and has been featured in Forbes, Vogue, Well and Good, InStyle, Parents, Refinery 29, Mashable, Adweek, and Pop Sugar. In our conversation, Dr. Javaid and I discuss perimenopause and menopause to clarify the facts and debunk the myths, because there are a lot of myths out there. Dr. Javaid also explains the benefits and risks of hormone therapy and the differences between estrogen, progesterone, and combination medications, as well as bioidentical hormones and natural hormones. And make sure that you stay until the end of the episode when Dr. Javaid discusses the cutting-edge treatments and research that she's doing in her clinics for sexual wellness, including microneedling therapy and Botox for vaginal dysfunction. Like I said earlier, pause this podcast and go grab a notebook and a pen because Dr. Javaid drops so much knowledge that you'll be having aha moment after aha moment, just like I did. And you'll want to take notes on pretty much everything that she shares. I am so excited to share this conversation with Dr. Somi Javaid about women's sexual health, including everything that you need to know about perimenopause and menopause as we explore hormones and our health. Somi, it is so great to meet you on the podcast. I know we met a couple weeks ago. Well, I didn't actually meet you. I heard you on stage at the Pause Symposium in Brooklyn, New York. And I was so impressed with your work that I reached out to you and I really wanted to have you on the podcast. So thank you so much for doing this with me today.
Thank you for having me. I love having these conversations. I'm so excited.
Yeah, I think it's a really, really important conversation to have. You know, as a South Asian woman who is now 52, and actually I just went through a breast cancer journey this past year, just finished my treatment a few weeks ago. These are topics that are so important to me for so many reasons. And so I'm just so grateful to have someone like you who is an expert in this field, who's doing such innovative, groundbreaking, types of things in women's sexual health. And so it's such an honor to have you here. So thank you so much for doing this with me.
Sounds like you've been through a lot,
Yeah.
And we hear that all the time. And that was my impetus, really, that women needed and deserved, this type of healthcare and couldn't find it anywhere in the traditional systems. And, so kudos to you for everything you've been through. And you're going to get to learn about a lot of options you have for any issues you may be experiencing. Yes.
I know. I'll try not to turn this into a consultation for myself, but I know I'll have lots of questions. I'll have to do that with you another time. But, I really wanted to start off with this question. We're talking about in the month of November, hormones and our health on the podcast. And of course, women's health, women's sexual health is so important. This is a good place for us to start, given what we just talked about is, what is sexual health? What does that really encompass? Because you're very specific on using the the terminology of women's sexual health rather than just saying OB-GYN. So what does that really mean to you?
So, for me, talking about all of the domains of sexuality, and what do I mean by that? When women come and talk about their sexual health, it can be about pain, it can be about satisfaction, it can be about orgasm, it can be about arousal, it can be about lubrication. So, there are many facets of our sexuality that can be impaired or not at goal, right? There's not, for a lot of men or for male patients, usually it's an anatomical issue. Now, men definitely struggle with decreased libido, but most of the pharmacotherapy and treatments that are out there are about a physical problem, right? Erectile dysfunction. But with women, it is so multifaceted. And so that is what we mean when we talk about sexual health. Is it a pain issue? Is it an arousal issue? We want to talk about women's pleasure. And there are validated tools, one of them being the Female Sexual Function Index, that providers can actually give to a patient. They can fill it out. It's a survey. And we can then diagnose, where a woman is struggling with her sexual health, and then come up with a formulated plan for that patient. Now, some patients are struggling with all of the domains of sexuality, right? Some women, it's very specific. I only have pain, or I only have problems with my sex drive. And so that's what I mean when we discuss sexuality. And why is it important? There was a survey in 2021 that came out that almost 26% of Americans were not having sex at all. I see women who lose relationships and partners because they don't understand what's going on with their sexuality. And their partners interpret their low sex drive or maybe their sexual pain personally as if there's a problem with the relationship, when really it may be menopause that's causing the sexual pain, or a woman has HSDD. And people are, what is that? That's the medical terminology for low libido, hypoactive sexual desire disorder. 1 in 10 struggle with that. And yet when I ask patients if they even know what that is, they say no, but everyone knows what ED stands for, erectile dysfunction. So it's fascinating to me. And so it is such a healthcare crisis right now for women in this country to be able to get really good sexual health care and sexual health care options.
Right. And so what's coming up for me also is that, being an MD as well, like we went to medical school and it was always about the two sides, right? Either when you're getting pregnant or getting ready to get pregnant, or, the time of from puberty till pregnancy. And then there's that time from, perimenopause to menopause. And like all of the stuff in between is not talked about, not important, not associated with women's health, which I think is, what you're kind of getting at, is that it's this middle time, which we're in so much of our life in that period, that we don't talk about in women's health, quote unquote. Right. And so it's sort of like, let's talk about all of it, right? Which I really appreciate.
No, we have to talk about it because there are so many health benefits to sexuality: lowered blood pressure, bolstered immunity, a reduced risk of depression and anxiety, reduced risk of losing a relationship, lower stress levels, you sleep better. We know that people who are sexually active, who desire to be sexually active, have improved confidence, better cardiovascular health. And so there are a lot of benefits, and you burn calories, which a lot of patients joke about, but it's true. And you also, maintain pelvic floor health. And so I think we have to talk about sexual health. And we've gotten very comfortable in this country talking about, men's sexual health, not so comfortable talking about women's sexual health,
Right.
unfortunately.
Yeah.
Yes.
Yeah, no, I think it's a great point. And so I actually am going to jump ahead. We're going to come back to this, specifically in a little while, but I want to start by, let's frame it with perimenopause and menopause. And the only reason I'm going here is, again, it's hormonal health, but I get so many questions from this audience, from this listening community about perimenopause, menopause, hormone treatment, et cetera, et cetera, et cetera. So I have you, an expert in this field. So I'd really like to jump into that. And then we'll come back to sexual health specifically. But can you just start by maybe defining, what is perimenopause? What is menopause? What are sort of the hormonal changes that are happening? Sort of like almost a primer, a 101 on this, so that the listeners really can understand, because I do think it's very confusing sometimes to understand, like, is it just about the symptoms? Like, not really understanding, why am I going into this period of life? What's happening?
Oh, for sure. So, menopause and perimenopause are sister diagnoses and can mimic each other, but I'm going to give you a very clear definition. So, menopause is 12 consecutive months without any bleeding, or we can measure an FSH level, which is the quote unquote menopause hormone that really elevates in your blood when you go into menopause. And we can make the diagnosis either based on the lack of bleeding for 12 consecutive months or with blood levels. And the reason the FSH is going up, the follicular stimulating hormone, is because estrogen and testosterone are kind of plummeting as we go into menopause, because we are leaving our reproductive years as far as childbearing. Perimenopause can have all the same symptoms of menopause. So, from head to toe, there's over 30 described symptoms of menopause. And perimenopause can mimic everything. The only exception is that there is still some type of bleeding in perimenopause. And so, for some women, it is still monthly. For some women, the cycles have gotten further apart. And so, for some women, the transition right before menopause is they actually get closer together. And so that's the difference between perimenopause and menopause. And the average age of menopause in the United States is 51 plus. And then perimenopause can be up to 10 years preceding that. And so some women can start perimenopause in their 30s. It's very jarring, and they're very shocked that it can start so young. And a very, very strong predictor of when you are going to go into menopause is actually when the women in your family went into menopause. And that's why it's so important to eradicate stigma, taboo, and shame. So many times I ask women, like, when did your mom, go through menopause? Oh, we don't talk about such things. But it would really help illuminate, when that's going to happen to you if you understand your family history.
Yeah. Yeah. And so those are sort of the clinical definitions, so you can understand, as far as your menstrual periods, the sort of the patterns that you're seeing. From a hormonal perspective, really what's happening is estrogen and progesterone are starting to go down and tank, and FSH and LH are going up, right?
And
Specifically.
the testosterone is also the big one. I call that the hidden hormone because we don't talk about it enough in this country. And it's just as important for women as it is for men. We all make it, it's measurable in our bloodstream. We just have a fraction of what men have circulating in their system. And really, we know that testosterone is what supports all of those domains of sexuality and a lot of our genital anatomy. And so testosterone is very vital. And I always joke that it's the hidden hormone. But yes, estrogen is really declining. And that's when people start to notice, the symptoms of menopause, the hot flashes, the insomnia, the vaginal dryness. And so all of the things that begin to happen. And so that's what menopause is. It's estrogen withdrawal. Estrogen is this great feel good hormone. I describe it like dropping from, being used to 6 cups of coffee a day and having all that caffeine. And then all of a sudden you drop down to 0. And so that withdrawal is the reason women experience, or can experience all these symptoms.
Right. And so, what are some of the common symptoms that women will feel or will experience as they start to move into perimenopause and then menopause? Some of the common ones, and maybe you could, explain sort of why does that happen also?
So there is some mild cognitive decline. And what do I mean by that? Women will start to experience maybe some word finding or forgetfulness, like where did I put my cell phone? Where did I put my car keys? And it may happen, more regularly than what they were used to. I already mentioned, hot flashes, problems sleeping, dry skin. Dryness is because estrogen is hydrophilic. It likes water, it pulls water with it. And so as estrogen levels decline, we experience dryness everywhere, not just vaginal dryness. And so that vaginal dryness can lead to painful sex. We actually see changes in the vagina. So a normal healthy vagina has these beautiful folds that are called rugae, and the vagina is deeply colored like this pink color for most of us. And so as we go into menopause and we lose our hormonal levels or they start to go down, we start to see a loss of those folds and actually thinning of the vaginal tissue. And so then rather than looking like an accordion so we can stretch and accommodate our partners, it becomes more like a tube sock. And it's very hard to stretch that tissue. And so that's when people describe burning and tearing with intercourse. And we describe this collaborative symptoms of both the bladder and the vagina, more frequent vaginal infections, bladder infections, urgency, frequency, painful sex as genitourinary syndrome of menopause, or GSM. Women can experience weight gain, particularly in the midsection, as both our metabolism changes, but then also where our body decides to deposit extra adipocytes or fat cells. And in the reproductive years, typically for most women, it's in the breast or hips and thighs. As we move into this menopausal phase, women describe having this, midsection that's getting larger where they didn't have that before. And they're like, Dr. Javaid, what's going on? Loss of bone density. So these are the invisible symptoms that I describe. So in the first couple of years after menopause, we can lose a lot of our bone density and it happens very rapidly. And it's because of that loss of estrogen. Our risk of cardiovascular disease all of a sudden increases and starts to mirror men. Sleep disturbances, either inability to fall asleep or waking up in the middle of the night, a lot of the times because the temperature differences, anxiety, depression, hair loss. I mean, it sounds so depressing.
It does.
I'm like saying all of the things that can happen, but what we're going to talk about are there's so many things to do about this. And so a lot of the sexual side effects are due to the drop in testosterone, and most of the other things that I talked about, the bone loss, the dryness, are attributable to the lower estrogen levels.
Okay. Yeah, that's an amazing explanation of a lot of the side effects. And one of the things I want to just click into is the bone density loss, because so
Yes.
many of these listeners are very health conscious, and they're hearing about why their doctors are saying do weight bearing exercise, do this, do that, and it's really because the estrogen is protective against bone density loss, right? The way our osteoblasts work, it's preventative. And so when you have that decrease of estrogen, you're going to have a higher risk of bone density loss, really.
Yeah, so estrogen is our biggest protector of bone. There's nothing else that's equivocal. And so if you are a candidate for hormone therapy, that's what I recommend. I'm a big proponent of hormone therapy. It is finally the party line. We have actually honored and stated that we actually did more harm than good by withholding hormones from women that are candidates or patients that are candidates. And so I think, we all read that article that came out earlier this year about how women have been truly misled in menopause. Prescribers stopped prescribing, doctors stopped learning, women threw out their medications. And really, this has been going on for 2 decades. And it's so sad because there's so much data that followed the WHI study that was stopped prematurely, that really scared a lot of women and practitioners. And what makes me really sad about that is we didn't share the glorious bits of data that we got out of that women that were in the estrogen only arm actually had a decreased risk of developing breast cancer. They had a decreased risk of dying from breast cancer if they developed it. Overall decreased risk of mortality. And the study was stopped prematurely, as you know. And there were multiple studies done after that showed the prolific positive benefits on heart, on brain, on bone for hormones, and no press conference was called. And so really, we have done a disservice for a very long time for a lot of women.
Yeah, that's something actually that I think I was absolutely stunned by when I was at the conference 2 weeks ago when I met you, is just hearing provider after provider, expert after expert in women's health, women's sexual health, talking about the WHI study, which is the Women's Health Initiative study that was done about 2 decades ago, and some of the just misguided theories, misguided thoughts about what that study showed. And it was sort of taken out of context, not actually what the findings were. And it totally sort of had a domino effect, exactly what you said, of providers saying, I'm not going to, prescribe hormone therapy, and then women saying, I don't want hormone therapy. So let's clear up a little bit of sort of the myths and misconceptions, because I think this is really where there is so much debate and talk, especially among patients too. You'll hear the two sides. I don't want to do hormone therapy, or I do want to do hormone therapy, or I want bioidentical or natural, or I want the medications. There's so much confusion. I would love it if you could help us clear up a little bit of this and maybe give people a way to think about this whole area of, and as you said, you're a very big proponent of hormone therapy. So let's just dive in there.
I am a big proponent of hormone therapy in the appropriate patient. I am also a big proponent of patient choice. And so as long as my patient understands risk benefit analysis and is not led by myth, and she's opting out of hormone therapy, that's fine. Her body, her choice. When I get scared is when patients are making decisions about hormones based on inaccuracies or myths. And so we know that study was poorly designed because it included a lot of older women who are not typically, started on hormone therapy, 70 to 79. It underrepresented patients we normally would start on hormone therapy, that 50 to 59 age group. And so what I want women to understand is that if we take transdermal estrogen, for example, so there's two buckets of hormone therapy. There's systemic, or, that is full dose hormone therapy. And then there's just localized therapy that you use, in the vagina. And that can be an insert, it can be a cream. And that is just to treat GSM, or the localized symptoms of menopause that I had addressed earlier. And then there's full blown hormone therapy. And that can include estrogen and progesterone, and then testosterone, if your doctor is willing to prescribe it, because currently in this country, despite all of the data and a NAMS statement, NAMS was North American Menopause Society. They have since rebranded to Menopause Society and have practice guidelines and actually support testosterone therapy. And there was a global consensus statement a few years ago that came out talking about the benefits of testosterone therapy, but we do not have an FDA-approved testosterone-only treatment currently in this country. And so things I want women to know is if they go on full-blown hormone therapy, a transdermal, what do I mean by that? So a non-oral medication, so either a patch or a spray or a gel, is much lower risk than the oral medication. So that's the first thing that we know. And so transdermals are actually not proven to be thrombogenic or cause blood clot like the oral medications. We're still very cautious in that patient population. Progesterone, this is where until now everyone's been in agreement, but there's a lot of doctors who now will prescribe progesterone to women even if they don't have a uterus. Typically, and I am still of the thought process that if you are in menopause and you have a uterus, you will be put on estrogen and progesterone. And the reason is estrogen can increase your risk of endometrial cancer. So that is true. And we put you on progesterone to balance that out. The other benefit of progesterone is it makes people sleepy. And so they love it for the sleep benefit. Women who do not have a uterus do not need to be placed on progesterone, so they will be offered an estrogen-only option. And then, like I mentioned, testosterone can be delivered in a multitude of different ways. Some providers will prescribe male testosterone at a much lower dose. I don't like that as much because it's costly for patients and can be very hard to titrate. We can compound testosterone. So, as long as it's a good, reputable compounding pharmacy, which there are a lot out there now, women can use it transdermally or on their skin. And then there are also pellets that women can use, which look like little Tic Tacs and can be placed underneath the skin with a very minor procedure. Pellets have gotten a very, very bad rap in this country because there's a lot of hormone centers, pop-up centers that are doing this without any expertise, without a patient actually seeing a provider, without checking serum levels or checking blood levels. And that can be very, very problematic. So my advice to patients is make sure you find a menopause provider that actually specializes in hormones, either an OBGYN or a nurse practitioner or a PA that actually has had adequate training, because currently less than 20% of providers are trained in this country when it comes to menopause care. The other thing I want to tell women, and I know you heard this last week, you're shocked about, is even though the vaginal medications, now there is one that is delivered in the vagina that goes full blown, but most of the time, the majority of the medications that you put in vaginally are not full blown hormone replacement therapy or hormone therapy, but the package inserts are the same. And so you will go home and you will open this up. And even though a fraction of it is absorbed into your bloodstream, you will read that you have risk of dementia, stroke, heart attack. And so patients are very, very scared to take, these localized hormones, even though a lot of oncologists are on board with it because it really can help mitigate those symptoms of GSM that I was talking about earlier. And I think the other really important take home message is that hormonal window or that menopause therapy window that we talk about. Hormones are most beneficial within the first 10 years of menopause, ideally within the first 3 to 5. And it's because you're trying to protect that bone loss that starts to happen. But that's when you can really also help prevent that cardiovascular risk, help with the cognitive, changes that start to happen. And obviously, the younger we are, the less risk we have of other, disease processes that can happen. And so I think if you really want to make a positive impact and you are going to opt for hormones, the earlier, the better.
Yeah. And so I think that touches on such a myth and a misconception that there's a certain time later that you should start hormone therapy, not earlier, right? That's a common myth of like, oh, I don't need to do it until I'm completely in menopause, right? Mm-hmm. And so I think that's sort of the message here is that it is good to start early when you start to see some of those changes, to go and talk to a provider who is trained so you can figure out what you're going to be doing.
Talk to a provider, get the diagnosis of menopause, and then, get on therapy if you so choose and if you are a candidate. And sometimes, I don't like to blanket absolutely not, because it really depends. I think there's a lot of emerging data, and that's where it's precision medicine. You really take a patient's history, both personal and family history, maybe their genetic cancer, screening, what they have been through. And then sometimes you have to talk to the other providers. Like a lot of times, we do a lot of survivorship care per MD, and we get the oncologist involved and we say, hey, this is our plan. This is what we want to do. And they will say yay or nay. And then, we'll talk to the patient and make a decision together as a care team.
This episode is brought to you by Vimergy. Over the past 8 months, I've been asked by so many people what I've been doing to help myself through the difficult journey of a breast cancer diagnosis. And while I credit so much of my healing to Western medical treatments of chemotherapy, surgery, and radiation, and the integration of using food as medicine, acupuncture, meditation, and time in nature, there's another tool that I know has been absolutely critical, and that's the addition of supplements. Because the reality is that in this modern world, it's not easy to get all of the nutrients you need through food alone. And with the colder months and the holidays approaching, taking supplements to boost energy and support health is even more important. That's why I like products by Vimergy. Their products are non-GMO, gluten-free, soy-free, vegan, and paleo-friendly. and are rigorously clinically researched, which means that you can feel confident in their formulations and ingredients. I especially like their magnesium glycinate supplement, which I take daily to support sleep. Let Vimergy's products help take care of you while you take care of everything else. Visit Vimergy.com and enter code Avanti-VIM, V-I-M, at checkout to get 5% off your first order. That's Vimergy, Vimergy.com, code Avanti-VIM. These statements have not been evaluated by the Food and Drug Administration. Products are not intended to diagnose, treat, cure, or prevent any disease. I want to back up for a second and talk about your perspective on, the medications that you spoke about, but then, this idea of bioidentical and then natural supplementation. Because again, this audience is sort of really, really open-minded and wants to know about all the options. And so can you talk to us a little bit about sort of what your perspective is on bioidenticals, supplementation, et cetera?
Yeah, so I will tell you, not all are created equal. So bioidentical just means that if you look at the hormone underneath the microscope, that what you are taking is identical to what your ovaries were producing. And so, for example, the drug that was studied in the WHI, Premarin and Prempro, was not bioidentical. Premarin was originally derived from pregnant mare urine, Premarin, and I think had upwards of like 17 different molecules of estrogen. And so then most women assume that if they want something bioidentical, they have to pay a fancy hormone center lots of cash. That's not true. There are FDA approved products that your insurance will cover that are bioidentical. So you just have to either ask your provider or read the packaging. There are supplements are not all equivocal. There are some companies that have done their due diligence and there is a lot of data, and there are others that haven't. And so I love the company Bonafide. You will see a lot of OBGYNs carry them because that was the way that they decided to launch in the marketplace. And so some of the supplements that I like in this space, Relizen and Equel, and if a patient doesn't want to go the hormonal route, a lot of times people will think, well, if it's a phytoestrogen, it's not really estrogen. Well, no, a phytoestrogen, those are plant-based estrogens. Those are still estrogens, and they'll still, latch on to estrogen receptors in the body. And so you have to be careful about that. And I think, there are 2 FDA approved medications for hot flashes that are non-hormonal. So Veoza was the one that was just FDA approved this year. They're the ones that did this big, Super Bowl commercial. And then Brisdell has been around for a while. If a woman does not want to go on hormones and they want natural therapy for GSM, there are procedures that we can do. We just presented our data about radiofrequency and microneedling. There's CO2 laser. There are, you can go to a pelvic floor physical therapist. There are moisturizers. There are lubricants. There are medications, this, you're a physician, that we can use to treat, low bone density or preventative, for osteopenia, which is bone thinning, or osteoporosis. So really, if a patient does not want to take hormones, there are so many options, either FDA approved medications, off-label medications, digital therapeutics, and I'll get into that a little bit. So for low libido, for example, and let's say a woman is like, nope, I don't feel comfortable with testosterone. There are 2 FDA approved medications. Addie is one, Vyleesi is the second, and they both are completely non-hormonal, work on neurochemistry or work on the brain, which I call the biggest sex organ. And a lot of patients who are not candidates for hormone therapy are candidates for both of those medications. So if they want something like that, they can do that. There's also 2 great apps that I love that have data that also help women with sexual function. So one of them is called Rosie, started by a dear friend of mine, Dr. Lindsay Harper, and has data that it helps with the domains of sexuality. It is an app that teaches about female sexual function, but also has stories, erotica, that women can read to get them in the mood to help with desire. There's another app called Dipsy where women can listen to audio erotica, and it can really help support sexual function. A great study was presented last year talking about vibrators and how they can help with female sexual function, satisfaction, but also pelvic floor health. And so that's why it's so important to go into a practitioner because, that's where you can talk about hormone therapy. I don't want hormones, but I do want an FDA approved medication. Talk to me about, over the counter products or therapy or counseling. I mean, the options are limitless. And that's the other myth I want to get rid of. I still hear in 2023, grin and bear it, just drink some wine and you'll be fine. There's nothing we can do. And it's shocking to me that this is still happening to women now.
Right, right. Wow, I have to take that all in. That is so much information. And I think what you're really sort of providing right now is that there is such a range of what you can be doing in this time of life if you are having any of these symptoms that are related to perimenopause and menopause. It doesn't have to just be hormone therapy as we have, sort of thought about it. And, I really want to tap into one other thing is that we don't say hormone replacement therapy anymore. It's hormone therapy. I'm being very specific in how I'm saying this. I know that you are too, because why do we have to replace anything? It's about being therapeutic for women, right? It's like, why the replacement? It's such a patriarchal sort of term, I think, used in medicine.
And I had to catch myself because, for years, that's what I used to say,
trained.
HRT, HRT. Yes. And now we say hormone therapy because for the women who are opting not to, which is their right and their choice, they're like, we're going to embrace this part of our life. We're maybe not having symptoms or we're using other modalities and we don't need anything replaced. And that's fine. But I also don't want to shame the women who are opting for hormones and are feeling like they got their lives back. A lot of times I will start women on hormones and they are like, I feel like myself again, Dr. Javaid. I have clear, thinking. I can function at work. I'm not hot flashing anymore. And for me personally, I will tell you, I couldn't imagine not going on hormones. I've started my own perimenopausal journey. I'm 48 years old and it's funny. My first own 3 hot flashes, I did not recognize because the medical literature is so poor in describing what a hot flash feels like. I thought I was either having a heart attack or an anxiety attack. And I am not a sweater. I always, the hotter, the better. For me, I'm always cold. My hair was drenched. I was tachycardic. My heart was racing. I was pacing. And my husband is like, what is wrong? And I was like, I have no idea. And when the third one happened, I go, oh my God, this is what my patients are telling me, they're experiencing. I couldn't imagine having to deal with that all the time and trying to function.
Right. Right. No, I think it's so interesting because when you're a physician, you're trained to see it in other people, but you don't see it in yourself. It's the funniest, it's the most bizarre thing actually. And I don't even understand how that works, that we don't even recognize it in ourselves, but it is what it is, right? Okay, so I think that you do want to click into something you said, and this is not that is really, really important for the listeners is that there is no right or wrong. We say this on this podcast all the time when we're talking about Ayurveda. There's no good or bad. There's just what's right for you. And I think that that is really the point that you're driving home is that there are so many options. Because again, one of the myths that we have all bought into and have been hearing for so many years is that there's one way to do it, right? Either yes, you have to have hormones or no, you absolutely should not have hormones. There's like no in between. And then there's all these myths about, this is bad, this is good, that's bad, this is good. Like it's so confusing. And I think what you're really providing is this perspective of like, there is something for everyone. And it's all about having that conversation with a provider who knows what they're doing, who's been trained really specifically to really address these issues and understands all of the different options that you have, right? So I think that that's a really important point. So moving from that, because I know I have so many questions and I have like 15 minutes left with you. So I'm going to just, blow through these questions, is that how do diet and exercise and sleep affect perimenopause and menopause, like lifestyle and behavior modification? Can you talk a little bit about that?
Yes. And so diet is the other word I want to get away from, right? Because I think it sounds punitive and like you're restricting yourself. And so I say lifestyle modifications, or this is the way you're going to eat. And so, how do you compound some of this weight gain, and how do you protect your bones? And that's what I talk to women about. You are exercising for your bones, you are exercising for your cardiovascular health. It's so imperative to prevent, or decrease that risk of developing cardiovascular disease. And you are, revving up your metabolism, and you are strengthening your core and your pelvic floor. And so that is why we exercise in menopause. And so obviously weight bearing exercises, so walking is the easiest one. Really want to do something that helps your core. So whether it's yoga or Pilates, that also helps your pelvic floor, right? And will help you with some of the genitourinary syndrome of menopause. I am a fan of intermittent fasting. I think when we go a little bit too far with that is when women start to go a day without food. I'm not a proponent of fad anything. I'm not a proponent of elimination of anything. I believe in moderation. I'm never going to tell a patient, to stop drinking unless there's a true issue there, but moderation, right, for everything. And so, but intermittent fasting has been proven to be beneficial for women, particularly for weight gain, and can also help with some of that, menopausal weight gain, particularly around the midsection. Intermittent fasting also lowers our insulin levels. And we know that chronically high insulin levels can increase our risk of diabetes, cardiovascular disease, and a lot of cancers. And so I love intermittent fasting because it also reduces our risk of cancer. As far as sleep goes and sleep disturbances, if patients, a lot of times when they go on hormone therapy, I told you it, like particularly the prometrium or progesterone component can help. But the party line and first line therapy is cognitive behavioral therapy. And so, going to a sleep specialist, but there are things that you can do in your room that I have personally done, setting the thermostat a few degrees lower, taking a lukewarm shower rather than a hot shower before you go to bed, making sure that you're not stimulated with the phone, as you're going to sleep. There is now, mattress cover that can actually help with thermoregulation. There are pajamas. There are so many things that you can do environmentally to really create and promote better sleep. So that's very, very important. And then there are apps that also, here I am telling you to stay off your phone, but, put on the Calm app,
Yep.
put a story on, and then get your phone out of reach, and don't reach for it anymore. So many people want just a pill. Like, can you just give me a pill and make me go to sleep? Those pills are really meant short term. And even melatonin, even though it's natural, long term studies show that it's not safe. Be taken on a nightly basis. And then we become resistant to it and need higher and higher dosages. So really that's why, cognitive behavioral therapy and really making those environmental natural changes are really what we recommend to support sleep.
Yeah. And so many of the lifestyle changes that you talked about are just good for you in general. Regardless of, whether you're going through menopause or perimenopause, they're good for you in general to follow some of those things for good sleep hygiene, for, weight control, insulin sensitivity, all of those things. So it's all beneficial for you.
Well, we need sleep. Think about how horrible we feel when we don't sleep. And we know that a lot of repair mechanisms are going on, when we sleep. And so when we don't sleep, we're not only cranky, we don't think clearly, our body doesn't have its restorative mechanisms. We're more likely to gain weight when we're sleep deprived. We don't eat as well. And then it also negatively impacts sex drive. So when women aren't sleeping, and particularly chronically, they do not want to have sex on top of all of the hormonal changes. And so that's why sleep is so important. And I really want to stress that for women, concentrate so much on that number on the scale. And so, we are so much more than a number. And if we get away from that and focus on the other benefits of exercise, I think that is a really powerful message. And the other message that I want to tell women is, you talked about tailored therapy, but it's okay during the journey to change your mind. So some women may come in very anti or very scared about hormone or thinking they want to go on hormone. As you're going through your journey, you're allowed to change your mind. It's your body,
Exactly. You don't have to just be stringent to, one point of view or the other. Again, it's your body. You're allowed to make changes based on your experience too. Okay, I want to switch gears because I really want to talk to you about all the research you're doing, any preliminary findings or key insights. But I also really want to talk about some of your areas of interest in sexual health. And we kind of started the episode with this, talking about some of the other sexual wellness issues that you are hearing a lot about, with your patients, and some of the things that you're doing in your clinics, which will also kind of talk about your very, very super cool, innovative approach to women's healthcare with her MD. But, vaginal laser therapy, talking about orgasm dysfunction, pelvic floor health. Let's get into some of those areas. I know I just asked you like 3 questions at once, but we'll kind of go through all of them.
All right. So the first thing is, I started something called Her MD University so that 100% of our providers are trained on menopause and sexual health care. So we're very, very proud of that. What came out of that is we started pulling our data on our outcomes, and we were invited not to share one, but 2 of our posters because that's how groundbreaking our data is. And so we presented just last month, the Menopause Society, our radio frequency microneedling. So, you know how women use that on the face. So, what's microneedling? You purposely kind of puncture the skin and cause a controlled injury so the body repairs itself. So, you lay down collagen, elastin, and increase blood flow. And what we showed with microneedling and radio frequency in the vagina is that we had a 95% improvement in the symptoms of genitourinary syndrome of menopause and a 90% improvement with stress incontinence. And so this is not surgery. This is not hormones. This is a in and out procedure in the offices that's done with just local numbing. And so that's pretty amazing. And it's groundbreaking because, for a lot of cancer patients who may not want to take hormone or not candidates, it's a really nice, optionality. And so that was great data. The other area of sexual health that I'm really passionate about is something called vaginismus. It is the involuntary contraction of the muscles surrounding the vaginal opening or a problem with our pelvic floor, right? Pelvic floor really quickly are all the muscles that support urinary bladder function or GI function, right? Nobody wants to pass, gas, poop, pee when they don't want to. We have to have enough tone that we hold things in, but not so much tone that we cannot insert a tampon or have a pelvic exam or have intercourse if that's the goal. And so individuals with vaginismus, a lot of them can't have intercourse or they can't insert a tampon. And so we inject Botox into the muscles surrounding the vagina at Her MD. And what we noticed was a 95% improvement in their symptoms. And so prior to this, standard of care was about 63 to 75% improvement. And so we are smashing the status quo. And you can see me smiling ear to ear because data is the only way forward for women's healthcare and the way we are going to start to get these kind of procedures covered with insurance and truly, make a difference for women. And so that is, been my passion is to give women a space that is taboo and stigma free to talk about their sexual health care. There's been a huge gender disparity. There were 26 medications for men that were FDA approved, and they deserve every single one of them. But for a long time, there were only 2 options for women. And the first FDA approved medication took 6 years. Viagra was fast tracked in 6 months. And yeah. And so my goal is to really eliminate a lot of the barriers that exist and why we got here for women's healthcare. Because, I nearly lost my mother when she was only 45 years old because of our very broken healthcare system. And so I vowed that I would change the things. So time was a huge barrier, for access. Who can accomplish anything in 15 minutes? Data. So that's why I'm doing research, gender bias. And that's why our providers are all trained, lack of training, and then lack of decision makers. And so even though women outnumber men in the healthcare workforce, we're not in those decision making positions. And so most of our executive team and all of our founders and most of our providers are women. And so we're changing the paradigm that we know and, smashing those glass ceilings. And so at HerMD, we provide treatment for all of that. So orgasm dysfunction, arousal, libido, dryness, pain. And we take what we call a biopsychosocial approach, which means that we just don't prescribe a medication or a hormone. We take into account what's going on with your personal history, your hormones, your relationship. And it is that biopsychosocial approach, getting you into counseling, pelvic floor physical therapy, procedures, recommending apps, for example, that are really giving us these amazing outcomes when it comes to women's sexual health care.
Wow. I mean, I was so blown away by hearing you speak about what you're doing. And, from a personal standpoint, totally going to come to one of your clinics. So I'll call you about that later. After going through breast cancer treatment, these are all issues that I'm dealing with. And I have an estrogen positive tumor that I was treated for. So, a lot of the hormone therapies are off the table for me. So, many of them are, many of them might not be. It's just we'll have to see. But I need some guidance on that because I can't be my own doctor, of course. But what is next for you, my dear? I mean, you're doing some kick-ass stuff in women's health. I know you have clinics all over the country now. I mean, you tell us what's next. I can only imagine.
So one final thought, what you were saying. So yes, nine out of every 10 female cancer survivors are struggling with some type of sexual health care issue, and only 1 in 10 are offered treatment options. And so that's why we are so passionate about survivorship. I've raised $30 million up to date from minority female founder from Ohio. Doesn't happen.
No, it does not. Wow.
It does not.
But it did.
We have another, it did.
It did.
We have another location that is under construction in Nashville. And so that'll be our second location there. And then I'll be entering another round of fundraising early next year to just keep building out clinics. And the ultimate goal is 200. We'll see where we get, because so many women need this care. When we open our centers, we have wait lists of 500 to upwards of over 1,000 women that are accessing this care. Because women deserve menopause and sexual health care within an insurance-based system and an integrated model of brick and mortar so they can come in if they need to, but we also have virtual care. And so that's what I'm doing, training, teaching, and opening new centers and taking every stage that I can so I can just educate.
Wow. I'm truly amazed by what you're doing. Before we finish, can I ask you a couple really quick speed round questions? These are just a way for the listeners to get to know you a little bit differently. I didn't send these to you ahead of time, but really quickly.
No, it's perfect.
Okay, great. Complete this sentence. Sexual wellness is
healthcare.
Yes. What is one myth about menopause that we need to change?
That there's nothing we can do about it.
What's something that people often get wrong about you?
They think I'm an extrovert.
I would have thought that too, but I guess I know I'm not an extrovert either. I think a lot of us who teach, we're actually introverts, but we get up on stage and talk about something that we're passionate about, and it's totally different. So I get that.
Total extroverted introvert.
Yes.
Yes.
Exactly. What is something that most people don't know about you?
That I am a world traveler and an amazing cook.
Ah, amazing. We'll have to have dinner sometime together. What is one thing that you're really excited about right now?
I am really excited about, personally, I have some fantastic trips that are coming up with my children. And I mentioned I've been in 8 states in 14 days for work.
Yeah.
So I'm really focused on getting to spend some quality family time. We love discovering the world together. Work-wise, I could not be more excited about this new location that's coming up. It's like giving birth to another baby for me. Every time because I select every location, I'm still involved in hiring every provider. And so for me, that's what's really exciting.
Amazing. What's one thing that you're deeply grateful about right now?
Oh my God, I'm so deeply grateful for my tribe. Everyone asks, they describe me as superwoman, and I'm like, no, I'm a blessed woman because I have a team of providers that believe in this mission, that believe in me, even on days when I don't believe in myself. And I have a family that supports and loves me and lifts me up every single day.
What's a book that's on your nightstand right now?
Mother, Daughter, Murder.
Okay. Wow.
It is Reese Witherspoon's latest book. So I literally just bought it for a pleasure trip. Yes. So yeah.
What is a song that you're listening to on repeat right now?
Oh my God. That is so funny. You're on Your Own, Kid.
What's that?
So I'm a Swiftie.
Okay, you're a Swiftie. Okay.
I'm a Swiftie. Took my daughters this summer and had a blast, but I've been listening to her for a very long time.
Yeah.
It's a pretty prolific song if you think about it from the perspective of being a entrepreneur and a founder. There are days where it is glorious and you're on top of the hill, and there are other days where you feel like you're crashing and burning. And that's what it feels like when you're fundraising.
Yeah.
And you're trying to talk to a lot of gentlemen about women's sexual health care, and you're trying to get them to write very, very large checks. Mm-hmm. And so that is a song as I'm prepping for fundraising next year, because the preparations start way before. Sure. I've been listening to that one for motivation.
Amazing. So. I love it. Are you going to watch the movie? Isn't the Swiftie movie coming out next week, I think?
Oh my God, you are so funny. So Sunday I have a picnic planned with the girls, and then we are going to watch the movie. So I have 3 children.
Yeah.
My son's in college, and then I have 2 teenage daughters. Yeah. And so I'm traveling again for the next couple of days for work. And then I am coming home for the weekend, and that's what we're doing on Sunday. Yeah, a picnic and the movie.
The only reason I know about that is because I'm going to it with my college friends next weekend when we're having a reunion. It was like first on the list for one of my friends. So that's the only reason I even know that there's such a thing as a Swiftie movie. But I think this is a good place for us to end our time together. It's been so much fun. So I have just one more question for you. If I offer up the phrase to catalyze healing, what comes up for you?
Balance.
Somi, thank you so much for doing this with me. You have so much knowledge and you've been so generous sharing it with us. And I wish you so much luck. I will be following you on everything that's going on with your business and these amazing clinics. And I hope that you'll come back again. I think there's so many more topics that we should talk about that I would love to have you back. So thank you so much for doing this with me. Thanks again for listening to The Healing Catalyst. If you love what you heard, please hit follow and pass it along to a friend. And if you're feeling really inspired, please rate and review so that others can find this podcast more easily. To learn more, head to avantiKumarSingh.com. And to connect with me directly, find me on Instagram at AvantiKumarSingh. I'll be back next week and hope that you will be too. Until then, remember, with the right catalyst, you have the power to activate your own healing, because healing starts within.